The next thing I want us to talk about is cast care. As we start to talk about casts, you need to remember that there are two types of casts: plaster casts and fiberglass casts. Plaster casts go on wet, and we must let them air dry. Another important thing about plaster casts is that when you handle a plaster cast, you need to palm the cast. Pick it up with the palms of your hands. You don't want your fingers to make indentations in the cast. If they do, then you can get skin breakdown underneath. So palm the wet cast. And this would be particularly appropriate if the cast is a plaster cast. Another concern about plaster casts is that if they get wet, they get soft spots, and basically it dissolves water will dissolve a plaster cast. Now, if we talk a little bit about fiberglass casts go on initially wet, but they dry almost immediately. So we don't have to worry about air drying fiberglass casts, and we don't have to worry about palming the cast with fiberglass casts. Water does not dissolve a fiberglass cast. We don't really want to get water under the cast, but water on top of a cast is not going to dissolve a fiberglass cast. Most casted extremities will be elevated, and this, of course, is to prevent edema and swelling. Now, whenever a patient has a casted extremity, when the cast is applied, there is a dilemma. The person putting on the cast has to make the cast tight enough to keep the bones in alignment, but not so tight that it cuts off circulation. And the nurse's job is to make sure that that was done properly. So we do neurovascular checks. Now, if you're doing neuro checks, you may say to the patient, wiggle your toes, wiggle your fingers, pinch them, and you say, can you feel this? You're looking for whether they're complaining of excessive amounts of pain. When we're checking for circulation, you may indeed, let's say it's a cast on the arm, that you would pinch the fingers. And if you look at that, you're looking for blanching and then for capillary refill. You're also noticing the temperature as you touch the fingers. If it's too cool, that would suggest impairment of circulation. You look for how much edema there is. There's usually a little bit of swelling, but too much swelling can indicate an impairment of circulation. When you do the checks, you do them all at once. When they ask questions, they might say which finding indicates a neuro impairment, and that would be sensation or motion problems. Which indicates a circulatory impairment, that would be the color, the temperature, the swelling, the lack of capillary refill. Another concern for us as we talk about cast care is skin care. And there's a couple of aspects to this. Particularly with a plaster cast, sometimes the edges of the cast are quite rough. Now, if you've got rough edges, that can cause skin breakdown. So you might need to cut pieces of adhesive tape in the shape of a flower petal. Just think of a daisy petal, for instance. And you cut these pieces of adhesive tape and then overlap them around the edge of the cast. This is called petaling the cast, and that's usually done on people who have a plaster cast. Your fiberglass casts tend to be smoother on the edges, and that may not be necessary. Another aspect of skin care has to do with the fact that humans constantly shed their skin. Unlike snakes that shed their skin all at once, humans shed their skin constantly. So when you bathe, you're rubbing off skin cells. When you're sitting in the room, skin cells are floating off into the air. When you have a cast over an extremity, those skin cells have no place to go when they accumulate. And after 2 or 3 weeks in a cast, the itching is almost unbearable because you've got all these layers of skin cells accumulating. And your patients will do some rather creative things to try and stop the itching. They will stick pencils, rulers, coat hangers, knitting needles, knives, all kinds of things under the cast to try and stop the itching. And the mean old nurse has to say you shouldn't do that. Because if they get a scratch underneath that cast, Before you know it, they can end up with a huge, huge ulcer. So our job is to try and tell them not to do the scratching underneath the cast. One thing that sometimes helps a little bit is to take a hairdryer on a cool or an air setting and just blow some of the skin cells around underneath. Some patients say that helps. Don't use a hot setting. That's going to make it itch worse. But this itching is a serious concern. Children will stick anything they can under the cast. I think some children think that their cast is a pencil box because you can find pencils and crayons and all kinds of things under the cast. You need to be very alert to that. Now you might wonder, why in the world do we smell the cast? We smell the cast to pick up infection. You can't see the change in skin underneath the cast, so you have to use your other senses to pick it up. And infection has a rather distinctive odor. So it's okay. You should be out there smelling the patient's cast. I want us to take a look at traction. Traction comes in two major varieties, skin traction and skeletal traction. In skin traction, the weight is borne by the skin, and skeletal, it's borne by the bone. In skeletal tractions, you have pins or rods that go into the bone, and the weight is applied to that. Usually, skeletal traction can have heavier weights and longer periods of time than skin traction. We're going to start by looking at some of the types of skin traction. The first one I'd like us to look at is bucks. If you look at this picture down in the corner, this shows the boot that we usually use today with bucks traction. So the patient's foot and leg goes into this boot. You can see there's a spreader bar at the bottom, and the rope goes out and then attaches to a pulley and a weight. This is frequently used for people who have fractures of the hip. So you might see the patient with a fractured hip in bucks traction until they do surgery, until they do that open reduction internal fixation. Now bucks is intended to be a continuous traction. You might, however, ask to be able to open it up maybe once a shift to make sure there's no skin breakdown underneath. But if you're making the bed, the traction stays in place. So it's designed to be a continuous traction. Another type of traction for us to look at is Russell traction. Russell traction can also be used for fractures of the femur. This picture shows a child. You could also have it for adults. Quite often you see your older patients with broken hips in Russell traction. Now if you notice this traction, you've got a vertical pull as well as a horizontal pull. So now this vertical pull is in the popliteal area. And remember that both arteries and veins are close to the surface behind the knee. So you would really need to check arterial and venous circulation. You can see in this picture the foot plate that helps to prevent foot drop in this patient. This particular picture shows a child with a vest restraint. The restraint is optional. If you had a hyperactive 4-year-old, you might need a restraint. If you had a calm 8 or 10-year-old, you probably would not. If you have an oriented 70 or 80-year-old, you don't need a restraint. But if you have an Alzheimer's patient, you might need restraints. Restraints are certainly an optional call with that. Bryant's traction is used for little ones, children under 2 and under 30 pounds. This is also for fractures of the femur. You can note that Bryant's traction is correctly applied when the legs are at a 90-degree angle to the body, and you can just put your hand under their buttocks. That tells you that it's correctly applied. Now, this picture, I like this picture because this child has such a smile on their face. And that tells us that if you can manage the pain, what does a baby know? Doesn't everybody get to lay on their back with their feet up in the air for a couple of weeks? So if you can manage the child's pain and the parent's anxiety, the child will probably do quite well. Even though only one leg is broken, both legs will be up in the air. And they'll probably be in this for a couple weeks, and then they may be casted after that. Another type of skin traction for us to look at is going to be head halter traction. In this particular picture, we know this is going to be an intermittently applied traction, maybe for someone with cervical neck strain or even cervical disc issues. We have a variety of this where patients can go to the drugstore and they get an apparatus like this that will go over the bedroom door, the bathroom door, the closet door, and instead of a cast iron weight as pictured here, there's a plastic bag, and into that bag you put sand or water to the 2 pounds or 1 pound or whatever is prescribed for the patient. And the patient gets to sit and hang themselves for 20, 30 minutes, 2 or 3 times a day. Head halter traction can have varieties where the patient is going to lie horizontal and be on a continuous basis. Pelvic traction is at the other end of the spinal column. This would be used probably for people with low back strain, lumbosacral strain, maybe lumbar disc issues. And you notice that there's a pelvic belt, and then the weights. Now, this perspective on this picture isn't perfect, but remember the weights do hang from the end, freely from the end of the bed. They're not going to be touching the pole. They're going to be hanging freely. Notice that the knees are bent. Now when you have a low backache, what you do is you go and you lay in a fetal position. You turn on your side and you pull your knees up to your chest. You bend your knees, and that opens up the spaces between the vertebrae and relieves the pressure. Now when we want to apply pelvic traction, the way to get that same opening up of the spaces would be to have the knees bent. Pelvic traction can be continuous. It could be intermittent depending upon the situation. So sometimes it is a continuous traction for us. Now I want us to talk about some skeletal traction. And if you take a look at this picture of skeletal traction, you can see these pins, these rods, going into the patient's bone. And there are actually 1, 2, 3, 4, 5, 6 on either side. So this patient has 12 pin sites. Now this particular type of skeletal traction, the patient will probably be going home with this. Once it's been established and they're stabilized, they may go home with this for a number of weeks. The big concern about skeletal traction is pin site care. Those pins go right into the bone. If organisms, if bacteria are around there, they can be just transported and crawl right into the bone and give the patient an osteomyelitis, which is extremely difficult to cure. We've had a number of different practices on pin site care, but right now what most places are doing is either soap and water, saline, or even just plain water, and cleansing the pin site area and then applying an antibiotic ointment. Years ago we used to use a betadine solution, and we found that rusted the pins, so we no longer do betadine. And then we started doing peroxide, and the patients began to get aerobic or oxygen-loving infections because of the high oxygen level in peroxide. So right now it's just cleanse the area with water, soap and water, or saline, and apply antibiotic ointment. I want you to take a look at this next picture. This picture shows a balanced suspension traction. Now balanced means that we've got forces in several directions. So you can see a pull here, a pull here, a pull here, and then a counter traction going in the opposite direction. For the other types of traction, the counter traction was the weight of the body. Now we have a counter traction with a pull in a different direction. So that's what we're talking about with balanced traction. Suspension means that it's up in the air, that it's suspended above the bed level. You can see here a Thomas ring splint. You can see that ring. So we got this Thomas ring splint and the Pearson attachment that cradles the calf of the leg. You can also see here the foot plate to prevent foot drop. Once again, the restraints are optional. Now I want you to look at the picture and tell me how you're going to make this patient's bed. You want to make the bed from top to bottom, from head to foot, not side to side the way we normally make a bed. So you would have the patient, you would loosen up all the linens, take off the bottom sheet here, completely loosen it up and put the new one on. Have the patient lift up on this trapeze bar, and then you would scoot the linens underneath them. Patients in this kind of traction, we don't want side-to-side movement. So in order to prevent side-to-side movement, you're going to have them use the trapeze bar, pull themselves up, and put the linen underneath them. That would make a very nice question on the exam. It's a very practical nursing care issue. All right. We're going to begin to look now at osteomyelitis, which could be a complication of skeletal traction. We don't always know what causes osteomyelitis. It's usually a staph infection. It could be hospital acquired. Sometimes people come in with an osteomyelitis. People that have had surgery, as those who have had skeletal traction. People who have had compound fractures where the bone has punctured the skin surface would be at risk for osteomyelitis. It's very, very difficult to cure. The patients will be getting massive amounts of antibiotics. I've even seen the time when we were dripping them right into the bone. The pain is incredible. Bone pain is severe pain. It can destroy the bone, so that you can have severe damage to the bone. IND down there stands for incision and drainage, of course. The best advice I would have to give on osteomyelitis is please don't let your patient get it, because it's extremely difficult to cure. Let's do another question. An adult has a fractured radius. Which finding indicates the client does not have altered tissue perfusion related to the injury? 1. Palpable pedal pulses equal in both feet. 2. No complaints of pain. 3. Client is alert and oriented. 4. Radial pulse of 72 and strong on both sides. And the correct answer is number 4. Now, occasionally somebody wants to answer number 1. That's the one about palpable pedal pulses. It's very nice you got palpable pedal pulses. That's wonderful, but it has nothing to do with the fractured radius. Remember that the radius is the arm, and it would be radial pulses that we would be concerned about. So the radius is the bone in the lower arm that's on the thumb side. Ulna is on the outside. So we have the ulna and the radius. Now I want to look at several different types of fractures. If a patient has a simple fracture or a closed fracture, it means that the bone is broken in two here, and there is no break in the skin. The skin remains intact. This is usually reduced or set by closed reduction. And when they do closed reduction, they really just go and give it a good hard yank and align the bones. Now, if you're thinking that's painful, you're right. It's excruciatingly painful for the patient. And even if they gave a little local anesthetic, that doesn't do anything for the bone pain underneath. So it's painful, but it's a short-term thing. They do it, it takes only a few seconds or a minute or so, usually seconds, and they align the bone, and the patient does not need surgery. They will then put the cast over that. If we take a look at a compound fracture, you note that the bone is broken, but there is a puncture wound here. A piece of bone breaks the skin. This is also referred to as an open fracture. Now, one of the things that we're most concerned about with that, when you have a puncture wound, the Clostridium tetani that cause tetanus infections love puncture wounds. So you really need to ask the patient, when was your last tetanus shot? Because they would be at high risk for a tetanus infection. Another type of fracture we want to look at is a green stick fracture. This we see only in children. Now, a green stick fracture is exactly what it says. It's like in the springtime when the sap is starting to flow. If you were to go out and get a stick and break it, and you were to break a green stick, you would see that part of it would stay intact and part of it splinters and bends. And that's exactly what happens in a green stick fracture. Now, a green stick fracture is only in children. Adults don't get it. It's only for children. And the last kind of fracture I wanted to show you a picture about is a comminuted fracture. This means that the bone is broken and splintered into several fragments. Properly aligned, a comminuted fracture will heal as well. All right, so now let's do a quick summary. Simple fractures, no break in the skin, closed reduction. Compound or open fracture, break in the skin, they're going to need an open reduction, so they're going to need surgery for that. Green stick fracture, only for children, and comminuted fracture is splintered into fragments. That may be able to be reduced by closed reduction. It's possible they might need open, but oftentimes a closed reduction works. There's just a couple other types of fractures I wanted to mention. You will see references in books to fractures describing the angle of the fractures. So you will see them talking about an oblique fracture. One of the ones that I want to pull out for us to talk about is a spiral fracture. And that means that indeed it spirals, so that you have a large area of broken bone. So it's like a spiral around the bone. Spiral fractures usually result from twisting and turning. Now, a spiral fracture can happen if you go to fall and you grab a tree or grab something and you twist around it and you fall down. You could get a spiral fracture that way. But if you had a child with a spiral fracture of the humerus, that's the upper bone and the bone in the upper arm here, this may raise the index of suspicion about child abuse. It doesn't prove child abuse, but it's something that is a warning flag that says, check out and see if this could possibly be child abuse. And we're very concerned about child abuse, so I just wanted to bring that to your attention. Now, when patients have fractures, and those fractures are going to be either put in traction or casted, particularly when they're casted, there are a couple of complications from fractures I want us to talk about. And one is something called compartment syndrome. Compartment syndrome is muscle ischemia. So remember that any muscle that doesn't get enough oxygen will scream in pain. This muscle ischemia could be because the cast is too tight. So if the cast was put on too tight, or perhaps the cast was put on fine, but there's too much swelling. So the cast is too tight, there's too much edema, there's hemorrhage or bleeding into the area, and what it does is it cuts off the blood supply to the muscle. You get pain, and you can get permanent muscle damage in as little as 6 to 8 hours. So pay attention when the patient complains of pain. Most patients can tell you the difference between bone pain, nerve pain, and muscle pain. Bone pain has its own feel, nerve pain is electric shocks, and muscle pain feels different. And most patients can tell you This isn't the bone. There's something else going on. So pay attention. Now, if they have compartment syndrome, the first thing you might do, let's say you have a casted arm. They might cut the cast right in half, what we call bivalve the cast, so that you can lift the top part off. The bottom stays as a splint, and that alone might reduce the pressure. However, if the pressure is internal, if there's hemorrhage into an area, perhaps they need to do surgery for that. The other complication of fractures I want us to talk about is fat embolus syndrome. This is seen particularly in long bone fractures. So people that have broken legs, possibly arms, but it's very common in leg fractures. And what happens is a piece of fat comes from the bone marrow and actually forms into an embolus. So it gathers up some platelets and red cells that will attach to it, and it really becomes a pulmonary embolus. So all the symptoms you would see of pulmonary embolus with chest pain and dyspnea. Then there's one other additional symptom, and that's petechiae, or little tiny little bruise marks, like almost like little black and blue marks, but little tiny ones, particularly in the chest area. So if you had a question on the exam and they talked about someone with chest pain and petechiae in the chest area, we're thinking, uh-oh, this patient probably has a fat embolus. Now, there's a possibility of other kinds of emboli with fractures as well. Anybody that's immobilized, there's a risk of a DVT forming. That's why very often patients who have lower extremity fractures or are going to be immobilized because of fractures may be given an aspirin a day, and that may be to reduce the likelihood of fractures, of emboli. Now, an aspirin a day is not for pain control. A single aspirin a day is going to be to prevent clots from forming. There's one particular type of fracture I want us to look at, and I want us to talk about a hip fracture. The elderly is the fastest growing segment of our American population. Broken hips are very common in the elderly. Therefore, I think it's likely you might see this on your exam. And this picture shows for us two different types of fractures, the intercapsular fracture and then the intertrochanteric fracture. I want you to note that the blood supply to the head of the femur is not very good. It's adequate, but it's not terribly proficient. And in patients who have fractures, sometimes that's cut off. Now, with these types of fractures, one common approach is to use a pin. So the intercapsular often gets a pin, or if open reduction, internal fixation. They might have to use a plate for this intertrochanteric fracture. And sometimes the ORIF is all that's needed, and the patient will very soon be up and walking again when that heals. Other times the hip is either shattered too much or the circulation to the head of the femur is too poor, and the patient needs to have a hip replacement. Hip replacements can also be done for patients with arthritis-type conditions. Now, I want us to look at hip replacement for a moment. If you look at this picture, you can see a normal hip joint. And on the other side, we have a hip replacement. So notice what they do. They're going to cut off the head of the femur. So the top part of the femur gets cut off. They glue, cement this prosthesis into the shaft of the femur. So it's cemented right in there. And then they put a plastic cap up here in the acetabellum. And now you create a ball and socket joint. And after this heals, the patient is going to be able to walk pretty well. Now that cement or glue is probably good to last a good 10 years or so if it's not abused. Some patients who have a hip replacement when they're relatively young may need a replacement of the replacement when the glue or the cement becomes no longer effective. Now, we're going to do a question that deals with the nursing care of a patient who's had a hip replacement. A femoral head replacement was performed on an elderly adult. Postoperatively, the nurse positions the client with an abductor pillow between her legs. For which reason? Number one, this position will promote greater comfort. 2, abduction promotes greater circulation to the hip joint. 3, abduction will help to keep the prosthesis in place. 4, this position helps to prevent pressure on the sciatic nerve. And the correct answer is number 3. Abduction will help to keep the prosthesis in place. Now they like to ask about abduction. Remember, we put that pillow between the legs and keep it abducted. Abduction keeps the hip pointed into the socket. If the patient was to adduct, so that would mean the legs going together. Adduct, it tends to pop the hip right out of the socket. So if we were to summarize nursing care for patients who have had either hip replacements or an ORIF, have had the open reduction internal fixation of the hip, the 2 key words for us would be abduction and extension. So we put the pillow between the legs. Now I know they've had questions about how do you turn a patient who's had hip surgery. And it's the abductor pillow, or put a pillow between the legs while turning. Not after, because otherwise then during the turn you would get adduction. So the pillow is between the legs during turning. Now extension is important. Extension prevents your really sharp hip flexion, which could force the prosthesis out of the socket. Now the questions that could be asked about extension. For instance, we may use a high extended commode seat, something on the toilet seat, to raise it so that the patient doesn't have to sit way down, because if you sit way down and your knees go up, that puts your hip in flexion and can pop the hip out of the socket. So the high extended commode seats. They might ask a question that said, what type of chair would be best to put this patient in? You want a chair that is relatively high and firm. You don't want them to sit in a low sofa with a nice, soft, squishy cushion, because when you sink right down into it, your hip goes into flexion. So extension and abduction are the 2 key things in the care of patients who have had hip replacements and who have had hip surgery. Now I also want to take a moment and talk about a knee replacement. When you have 2 bones, they are never supposed to rub together. If you have bone rubbing on bone, it's excruciatingly painful. So bone that rubs on bone is painful. You're supposed to have some cartilage in between, a cushion in between, so you don't have bone rubbing on bone. In patients who have arthritis, and sometimes those who have had athletic injuries, for instance, that cartilage wears away and you have bone rubbing on bone. And then every step is painful. So this would be an indication for a knee replacement. If we take a look at what happens with a knee replacement, a cap is put over the femur, and then one over the tibia, and they put some fake cushion, cartilage, some fake cartilage in between. There are a number of different types of procedures. In some, the kneecap is totally replaced, and some it may not need to be. But the key point is they cap the femur, they cap the tibia, and put some fake cartilage, put a cushion in between. Now, when patients come back from a knee replacement, they're going to come back with this continuous passive motion machine. The physician prescribed the frequency and arc of the movement, But you can see there are little rollers in here, and this will constantly be moving. This is to keep it, of course, flexible and keep it from setting up. Now, for the first few days, this will be a continuous passive motion. As they are discharged and go home, this may continue to be a part of their physical therapy routine. As they begin to walk, they're likely to have an immobilizer put on, which keeps the knees straight until they are well established in their walking process. Most people with knee replacements will be doing very well before long, and they'll be walking pretty much normally.